Hemorrhaging. Hemorrhaging is a really important thing to assess as far as what mechanism of injury and what's going on with the patient, whether it be a trauma that happened and somehow they got their abdomen hit, they have a severed artery in their neck, they have a severed artery anywhere in their body, they are a female that is having a miscarriage and hemorrhaging that way, whether it is a rectal bleed, a GI bleed of some sort. There's different types of hemorrhaging, and we'll go into that later. The first thing you want to assess on a patient in an emergency situation is their blood pressure, their heart rate, their respiratory rate, and their oxygen, the skin color, cap refill. All of those things are important to assess in an emergent situation. Of course, the severity of the bleeding is going to change those assessments very quickly, so you have to intervene very quickly. So one of the highest priority is to replace the fluid and I would say control the bleeding. So wherever the bleeding is happening, obvious bleeds such as arterial bleeds and such, you would put pressure on those areas to stop the bleeding. And this slide, I'm going to go back and forth. This slide shows you the different pressure parts for hemorrhage control. I know they're showing the temporal artery. I've never really seen that unless there's a cut or a gash on someone's forehead. There's the facial artery right under the jaw, the carotid, the subclavian, the brachial, the radial and ulnar, and of course the femoral. These are the systems in the body that you need to put points of pressure to stop the hemorrhaging. The next thing I said was the fluid replacement. So in an emergency situation, you want to have 2 large bore IVs in a patient so that you can be giving blood in one and fluids in the other, because blood has to be given separate, and I think most of you know that. Wounds, this could be why a patient is hemorrhaging, or they just came in because they had, like I said before, they scraped it on barbed wire, they scraped their leg on barbed wire, they cut their arm on a piece of metal that was sticking out of a truck, or whatever the reason for the wound. The first priority is to stop the bleeding, like we just said. Putting as much clean material into the wound as possible before we can get to the primary closure event, which is usually where the physician in the emergency room will come in and start doing sutures. So cleansing of the wound is severely important, especially if it's a trauma where there's particles of dirt or pebbles of some sort, or some kind of bacterial inclusion into the body. Remember, our skin is the first line of defense, and if it's open, we need to clean it and close up the injury. The other thing is the delayed primary closure usually means whether or not how big the wound is. Sometimes ER physicians don't want to close the wound completely so that they trap in bacteria and white blood cells, and it causes an abscess. So delayed primary closure can happen where they close up most of the wound and leave a little part of it open. Tetanus prophylaxis is when someone is impaled with some kind of metal object or any other kind of object, and they could be exposed to the tetanus toxin. So trauma. So trauma is an unintentional or intentional wound or injury that's inflicted on the body from a mechanism that the body could not protect itself from. I've already given several examples. We're going to say motor vehicle accident, stabbing, shooting, violent injuries can be an example of a trauma, or maybe a sport injury, or it could be working on a ladder. I mean, it could be many things. So in the case of a victimization trauma where someone was in a gunshot wound, had a gunshot wound or a stabbing, that kind of thing, we look at the collection of forensic evidence. For instance, you would want, if it was a gunshot wound, you would want to preserve all of the crime area as far as the clothing, any DNA sources. We're not going to be in the scope of possibility. You're not going to be scrubbing the patient's body right away if the patient is alert, oriented, and still stable. Another thing is the mechanism of injury is also evidence, especially in a violent crime. You need to know details of the crime, like where it happened, who was involved, did you know the person, that kind of thing. Try to collect as much detail from the patient in that situation as you can if the patient is able, or if there's anybody that brought the patient in. Anything that you can collect as far as information on how things happened, that can be vitally important later on. So we as emergency nurses really play a big role on whether or not that person has justification for what happened to them, meaning get justice for what happened to them. For example, there's situations that I've had for traumas that happen, gunshot wounds I've given examples about. You have to play a role in finding out what's going on. And I gotta say, there's times when the person that was the gunshot victim or the victim doesn't want to turn in the perpetrator that did this to them. And that does happen more often than not. It's very, very surprising, but it will happen where they don't want to give up who did this to them, whether it be a gang-related thing, domestic violence thing, a friend, who knows. But anyway, you'll get that situation sometimes. Another huge role of the RN in a trauma situation is the education of injury prevention. So we need to educate patients on how they can avoid traumas, such as motor vehicle accidents, make sure that they're wearing their seatbelt, safety devices that they could be wearing that could help them prevent an injury to begin with. And in the future, if it's a minor trauma, of course, that's where you'd be doing the teaching. If it's a major trauma, it would be involving the family of the patient, how to involve everybody to be educated around how to prevent an injury. Nurses also play a role in the legislation part of preventing injuries, getting involved with legislation, local, state government legislations to get the safety measures or announcements out there, and being a part of legislation that protects people from injury. That's another part. Automatic protection, the nursing role in the emergency room for automatic protection and being involved in the legislation of safety and prevention of trauma is things like airbags, being on the tasks that the task force that actually invent those kind of things is really important. I don't think most people realize that you could play a role in that way as well in preventing traumas or injuries. Here, again, we're going over the priorities of care with patients that have multiple traumas. It's important, really important to understand that multiple trauma is a single catastrophic event that causes life-threatening injuries to at least two distinct organs or organ systems. It requires that team approach that we've been talking about. We often talk about how time is muscle on cardiac patients. Well, for trauma patients, time is also life. So we have to determine the extent of the injuries, like we talked about, getting clothes off, finding out where the injury is, and establishing priorities for the injury. If it's an airway occlusion, it's time. You got to get on this stuff. We also want to assume in a trauma that there's been a cervical spine injury, so then there's cervical spine stabilization techniques that you will learn as an emergency room nurse. Injuries interfering with vital physiological function like the liver, the spleen, the kidneys, those kind of things need to be addressed very quickly. So here we're going to discuss the management of a patient that has an intra-abdominal injuries, and this is part one. Blunt trauma or penetrating injuries. So blunt trauma usually involves things like motor vehicle accidents, falls, blows, or explosions can be another thing. Penetrating injuries involve are usually gunshot wounds or stab wounds, where the weapon has actually penetrated the peritoneum and has compromised vital organs such as the liver, the spleen. The intestinal organs are kind of secondary to that, but those are the things that you look for penetrating. High velocity gunshot wounds tend to do more damage, and stabbings tend to be something that can be managed with non-surgical interventions depending on the extensive part of the injury, if it has lacerated the liver, that kind of thing for stabbing. Abdominal trauma can cause massive life-threatening blood loss into the abdominal cavity. Blunt force injuries cannot usually be seen very quickly because it could be a slow bleed into the intra-abdominal cavity, and that can be something that the vital signs don't start to change, or the assessment of the patient doesn't really change till maybe late in the bleeding process for blunt traumas. Penetrating injuries, you automatically assume the worst and you treat with the highest level of care. The assessment, again, goes back to obtaining a history of the event, where it happened, what happened, who was there, why were they there, that kind of thing. Abdominal assessment and assessment of other body systems and injuries frequently accompany this kind of injury because, like I said, you're always assessing what the patient's vital signs are, the color, the abdomen, if it's distended, is it firm, is it bruised, is the whole hue, color of the abdomen, is it look like it's bleeding. Lab studies, a CT scan usually is ordered very quickly with either stab wounds, penetrating wounds, to get an idea of what is injured inside the body. Sometimes the abdominal ultrasound is happening, and they can actually go in and do an emergency surgery to open the abdominal cavity and stop the bleeding where it is. Says here, stab wounds, they don't necessarily go in with a surgery with a stab wound. Because the body kind of closes up as soon as the weapon is out of the body, usually it's already starting to repair, but sonography will help identify if there's any hemorrhaging in the body cavity itself. So management of the patient with intra-abdominal injuries includes these steps. You're going to ensure that the airway, breathing, circulation, like in any other situation where there's a trauma or an event happening, you're going to mobilize the cervical spine, especially if it was the mechanism of injury was like a fall, explosion, the person was pushed back. You don't know how much the rest of the body took the blow. Continually monitoring the patient, putting them on a cardiac monitor, and vital signs being taken every 5 minutes just to kind of get an idea of what's going on with the patient. Documenting all wounds on the patient's body. Some hospitals have charting where you actually have a drawing of the body and you can write in where the wounds are. If the viscera are protruding, you're going to cover with, it's similar to what you learned in second semester with evisceration, or when the bowel opens up outside of a wound, you're going to put sterile, moist saline on a gauze and put it over the abdominal viscera until it can be managed surgically. You're going to hold all oral fluids. I can't emphasize this enough, and nurses especially, tend to feel bad because hours can go by and they're waiting for surgery to happen, but we cannot feed these people or let them have anything to drink because we don't know if they're going to be going to surgery, and two, we don't know what's going on in their abdomen and whether they can even digest anything at this point. An NG tube can be put down to aspirate gastric contents just to make sure that they can get to the surgery quickly without having anything in their stomach. That's in a trauma situation as well. Again, tetanus, you'll see antibiotic prophylaxis, rapid transport to surgery. Like I said, this is the whole goal of managing intra-abdominal injuries. Again, refer to your readings. Page 2169 will help you with the assessment and diagnostic findings in intra-abdominal injuries. Next, we go to complications of crush injuries. Now, crush injuries occur when a patient is caught between two opposing forces, such as a moving vehicle, being run over by a moving vehicle, being crushed between two cars, being crushed by building material that collapses on you, things like that. The assessment process is the hypovolemic shock, because if there's any internal bleeding, again, we'll go back to the internal bleeding, there's a fluid shift that's happening from the circulatory system into the peritoneum again. And so that's when someone can go into the shock, or if there is an arterial bleed somewhere happening either outside or inside. Spinal cord injury is a huge thing that you have to look for. Erythema or blistering because of the material or whatever happened in the crush injury. Fractures of the spine, the pelvis, any of the extremities that got caught between the two forces. Acute kidney injury if the crush injury happens in the abdominal cavity somewhere. Again, management of all of these things goes back to our list of airway, breathing, circulation, and hypovolemic shock. It's going to be fluid replacement and blood replacement if needed. Spinal cord injury, we're going to make sure that their neck is stabilized in C-spine stabilization. Or erythema and blistering, skin, that's wound care. Fractures, we're going to stabilize those by splinting them. And the acute kidney injury, we may have to intervene with surgery. So those are the kind of things that you're going to have to look for in that kind of trauma. So now we're moving into another type of environmental emergency, the heat stroke. And here in Tucson, that's definitely a very real thing that happens. Typically, Tucsonans do not drink enough fluid to maintain homeostasis in a way that is non-labile. So especially the elderly, we'll go into some of the different things that you're going to look for. The elderly have very thin skin. They are unable to regulate their skin temperature. And if they, a lot of times, don't want to drink a lot of water because they don't want to have to urinate. So they tend to be most dehydrated because their body regulation systems are deteriorated a bit. So failure of the heat regulation mechanisms can cause death, obviously. That would be the worst case scenario. The types are the non-exertional, the prolonged exposure to an environmental temperature that's over 102. And that's really our heat in Tucson is always over, especially this time of year in the summer. So they call it the essential fluid loss. And you'll remember that from fluid and electrolyte balance. They lose a lot of fluid. Everyone does. So we need to be drinking a lot of water. External is a cause from a strenuous activity, mainly like exercising, working out in the heat. Air conditioner mechanics or car mechanics, people like that work in those kind of environments can be landscapers. We all know who's outside here in Tucson. So people that are not acclimated to the heat or acclimated to the heat from back east, maybe Maryland, the East Coast, they come out here to get the warmth and the sun. I can't tell you how many times I've had them say that they don't know that they had to drink so much water. And some people that are in places where there's oceans next to them don't tend to lose the moisture like we do because it's a dry heat. We heard that before. It's a dry heat in Tucson. And it's true because we don't have that moisture to kind of go along with our bodies. So people back east come here and they're like, I didn't realize I had to drink so much water. Manifestations can be CNS dysfunction, meaning disorientation. Their sodium levels are either too high or too low, elevated temperature of 105 or higher, depending on the heat exposure. Hot, dry skin, anhidrosis is usually when the tissues are very dry, the mouth is dry, mucous membranes are dry, skin turgor is going to be super long. tachypnea, the body tries to breathe out the heat and cool itself off, hypotension because of the fluid loss and the fluid shift. There's nothing to replace it, so it starts to deteriorate the body. And then tachycardia, because the heart's trying to speed up to cool off the body. So the goals in managing the patient with a heat stroke are to reduce the body temperature to 102 if it is above 105, obviously. We're trying to slowly reduce that temperature down. So you're going to use your airway breathing, circulation mechanisms to reduce the temperature to 39.2 degrees Celsius or 102 Fahrenheit as quickly as possible. Cooling methods involved are cooling sheets, towels, sponging, cool water. There's ice to the neck, groin, anywhere you can put ice packs on and cool the body. There's the cooling blankets involved having water systems through a tube and a blanket that has little gel bubbles that fill up with water, and the machine keeps the temperature at a certain level. Immersion into a cold water bath, that would be something that you could do on a if you're at home and something happens to a neighbor and that kind of thing, getting them into a cool water bath. I haven't seen too much of that in the hospital, but maybe a shower if you were working on a med-surg unit, you'd do it that way. But in an emergency situation, usually it's the cooling blankets and the ice packs that we use. Of course, you're going to monitor the temperature, vital signs EKG, the cardiopulmonary BP monitoring, their level of consciousness, INO. You're going to check labs, make sure that you know their level of dehydration. First thing you're going to do when the patient comes in exhibiting signs and symptoms of heat stroke are start an IV and replace fluids. Start an IV, replace fluids. Medications, some people can actually have seizures, so you want to give them anticonvulsants, potassium, sodium bicarb, benzodiazepines to slow the seizure threshold and reduce the seizure activity in the brain. So these are things that can happen in a heat stroke, and it can be very scary and can go south very quickly if you don't do these measures very quickly. So this is the last part of section 2. We're going to talk about the environmental emergency of frostbite. We don't tend to have so much of that as a problem in Tucson, but it is a trauma from exposure to freezing temperatures and freezing of fluid in the intracellular or intercellular spaces. That can happen if someone is up in a very high elevation. Even in Tucson, people going up to Mount Lemmon, getting exposed to the snow in the wintertime, people coming in from out of town that didn't really realize that they were that cold wherever they were. Manifestations are hard, cold, insensitive to touch because it's numb, may appear white or mottled. So they're talking about the extremities, maybe hands, feet, skin all over, may turn red and painful as it's rewarmed. I think any one of us has been in that situation where we were in a really cold pool and got out and were just numb initially, and then as we started to warm up, it actually hurt. Those are like the initial signs of frostbite that can happen if it was prolonged. So we'll say if somehow you broke through the ice going ice skating and went into the cold, deep cold water or the ocean water, that kind of thing, it's a controlled but rapid rewarming, kind of like what we were talking about with the heat stroke. You're going to kind of slowly warm someone up because the rapid warming is really tough on the body because you got to let someone get used to it. You can be in a circulating bath or a warming blanket. So just like the cooling blanket, we have warming blankets that have hot air that can be put on top of the patients. Many times you've seen that in the surgery area. They have warming blankets called the Bair Hugger, BAIR. Those are warming blankets that you can use to help warm patients up. Pain medicine, because it's really painful to have that heat to be warmed up again and have the circulation go back to that area. And not to massage or handle the tissue because the tissue is already injured. So massaging it or trying to get the circulation to it can actually do more damage, and they don't want you having the person walk if their feet have been affected for the same reason. So that is ending our section 2, and I will see you in section 3.